ears to hear it, hands to do God's work with, feet to walk with, and mouth to preach the word of salvation with. And may the angels watch over us. May we be as at last by the Lord's gift to the kingdom.
So pleasant day again to everyone. So before we officially start, may I call on Dr. Maria Minerva P. Kalimag, the project head of the UST Med 150 webinar series, to introduce our Dean and Assistant Dean for the welcome remarks. Dr. Kalimag.
Good morning, everyone. So welcome to the webinar this morning. And I'd like to introduce the Dean, Assistant Professor Maria Lourdes D. Maglinaw, Doctor of Medicine, UST Faculty of Medicine and Surgery, Class of 1986. Holds a Master's in Health Professions Education from the UST Graduate School, Fellow of the Academy of Filipino Neurosurgeons, and a recognized leader in the field of neurosurgery, both locally and internationally. Past president of the Academy of Filipino Neurosurgeons, past chair of the Women in Neurosurgery section of Asia, and traveling faculty of the International Society of Pediatric Neurosurgery. Our assistant dean, who's with us today, because the dean has previous engagement, is Dr. Professor Remedios D. Chan, MD, Doctor of Medicine, UST Faculty of Medicine, Class of 1981, a classmate, Masters in Health Professions Education from the UP NTTC HP, Fellow, Philippine Pediatric Society, Fellow of Philippine Society of Nephrology, Fellow and Past President, Pediatric Nephrology Society of the Philippines. Chair, Association of Philippine Medical Colleges, APMC Committee on Curriculum, and member, Philippine Accrediting Association of Schools, Colleges, and Universities, PAASCO Medical Commission. I now request Assistant Professor Mimi D. Chan for her welcome remarks.
Greetings. Greetings, beloved UST Medicine alumni, to our faculty members of the UST Faculty of Medicine and Surgery, dear students, colleagues, and friends. On March 11, 2020, approximately 14 months ago, a new scourge of mankind, the COVID-19, was declared by the WHO as a pandemic. Most of us, and probably all of us in this virtual platform, have never seen or experienced a pandemic in our lifetime. But in a wink of an eye, we all came face to face with a curse that has tormented humankind for the last 14 months, causing immeasurable anguish and misery amongst all of us. The enormous socio-economic cost of this pandemic is incalculable, as is the substantial loss of lives. From the outset, scientific researchers and investigators have scrambled to find answers to questions as to why this novel coronavirus, unseen in human beings, is wreaking so much havoc on human life. It is a new virus, but scientists are learning so much about this new enemy. Aside from diagnosis, treatment, and prevention, abundant knowledge on the basic pathophysiology of the disease have been acquired. Cytokine storm is now synonymous with this deadly viral infection. Broadly speaking, it denotes a hyperactive immune response characterized by release of several mediators of inflammation, leading to organ failure or death. The cytokine storm may be the most crucial aftermath of COVID-19 infection, but another factor, albeit rarely mentioned, is the catecholamine surge that is inherently a response of the body to any major physiologic stress. Does this have a significant impact on the disease? Is this a troublesome twosome? Your guesses are as good as mine. Fortunately, we have the expert, multi-awarded physician, endocrinologist, researcher, and teacher, my batchmate of the Magilas Class 81, Professor Dr. Leilani Asis, who will expound and shed light on the critical interplay of these two events in patients with COVID-19 infection. The UST Faculty of Medicine and Surgery will be celebrating her 150 years in 5 days. And part of its sesquicentennial celebration include the UST Med 150 webinar series featuring esteemed alumni who will be giving lectures about their topics of expertise in their respective fields or specialty, as well as on more mundane topics of life outside the bubble of medicine. Today, we are indeed fortunate to have Professor Dr. Asis to give this talk. I would like to thank the organizers of this webinar, headed by Professor Minerva Kalimag and Professor Ivan Villaspin, for making this today's event possible, and for the many more upcoming webinars that their group will be featuring. And may I take this opportunity to invite all of you to join us virtually in the sesquicentennial inaugural ceremonies on May 28, 2021, this coming Friday. We will have no less than the Secretary of the Department of Health, Honorable Secretary Francisco Duque III, who belongs to UST Med Class 82, to give the keynote address. The highlight will be the presentation of the sesquicentennial marker, which will be unveiled at its original site in Plaza Santo Tomas Intramuros the following day, May 29. Tackling COVID-19 is almost an impossible task, but with concerned researchers like Professor Asis, the fight against COVID-19 becomes less daunting. We hope you will find this webinar fruitful and informative. Thank you very much, and let us all continue to be safe.
Thank you very much, Dr. Mimi, for that very wonderful and inspiring message po. And in line po with what Dr. Mimi has mentioned, let us now view our teaser video for our sesquicentennial celebration. For those of you who won't be able to, who know someone po who can't join this Zoom platform because we have reached our maximum participants, our YouTube link is seen on the in the chat box, and you can forward this to them. And we will be posting this also in our social media pages. So kindly watch this teaser video for our May 28th kickoff. So I hope everyone is ecstatic for our sesquicentennial celebration. As seen in the video, we have a lot of activities every month for our year-long celebration. No pandemic can hamper our Thomasian spirit as we continue to showcase that we are the biggest, the brightest, and the best medical school. So before I officially or formally introduce our speaker, I would like to remind everyone of some house rules to ensure a smooth sailing virtual experience. So kindly mute your microphones, and should you have any questions or comments, kindly type them in the chat box and we will read them during the open forum later on. So ladies and gentlemen, flashed on the screen before you is a woman of grace and substance. She graduated from the UST Faculty of Medicine and Surgery in 1981. Her career advancement includes internal medicine residency training at UST Hospital and fellowship training in endocrinology and metabolism at the National Institutes of Health in USA, and a doctorate studies in the same field at Gifu University School of Medicine in Japan. She entered the academe at the UST Faculty of Medicine and Surgery and has been teaching for the past 29 years. With her academic undertakings, she furthered her professional growth to obtain a master's degree in public health and medical education focused on distance education. She established the UST Master in Public Health International Program in collaboration with the University of Leeds and is currently its program director. Her community and public health involvement includes establishment of the Subic Bay Metropolitan Authority medical facilities that now serve over 300,000 employees. Research is her utmost passion, and she authored and likewise co-authored numerous publications in the field of pituitary tumors and adrenal abnormalities, diabetes, thyroid disease treatment, dyslipidemia, and hypertension. She is a member of the international group engaging in catecholamines, pheochromocytoma, and paraganglioma, the topic she fits well and very much related to her lecture today. She has received numerous awards in her professional journey. Worth mentioning are the Dangal ng UST Award in 2004, the Dr. Cyrus Katzen Pheochromocytoma and Paraganglioma Humanitarian Award in Washington, D.C. in 2012, and the 2017 Gusi Peace Prize International Award in Medical Education, Research, and Patient Care and Service. She has been a consistent recipient of the UST Rector's Gold and International Publication Award since 1999 up to the present. Colleagues, I am very proud and honored to introduce to you our enigmatic and omniscient speaker, Dr. Leilani B. Mercado Asis.
Thank you very much, Tina, for the kind introduction. Kindly able, ayan. So I will screen share. Can you enable me, please?
Okay po, Doktora.
Okay, thank you. So today's topic is a very relevant topic. The deadly duo in severe COVID-19, which we less understand, that of acute catecholamine surge and cytokine storm. I have no conflict of interest related to the topic, but this is a paper published with the same title last March 2021 at the Endocrinology and Metabolic Research Journal. So I will start with simple catecholamine physiology and then move on to adrenoceptor-mediated clinical and evolving manifestation of pheochromocytoma, which is now different from what we learned in the medical school. The cytokine storm or cytokine tsunami syndrome and Takotsubo syndrome, two syndromes in severe COVID-19 infection, and the role of alpha and beta adrenoceptors blockade in curbing the fatal course of severe COVID-19 infection. So the sympathetic neurons and the chromaffin cells come from neural crests, and they have both the characteristics catecholominergic phenotype properties. How to be assigned for these chromaffin cells to go to adrenal and extra-adrenal areas like the ganglia in the sympathetic chain depends on the transduction signal pathway, specifically glucocorticoids. The mother substance is tyrosine with enzymatic metabolism. This is converted to dopamine, norepinephrine, and epinephrine, which are the three major catecholamines circulating in the blood. The presence of PNMT or phenylethanolamine and methyltransferase in the adrenal only makes epinephrine the major catecholamine coming from the adrenals. When we ask for the blood level of catecholamines, now we request for blood metanephrine and normetanephrine, which are enzymatic products of epinephrine and norepinephrine respectively. When we request for urine, we say urine metanephrines with an S, and that will include both metabolic products coming from the two catecholamines. Less common is dopamine. The specific metabolite is 3-methoxytyramine, which is not commercially available but very active in research. It can predict the size of the tumor in the sympathetic ganglia, which we call paraganglioma. It can predict if the characteristics is malignant or not. So the catecholamines attached to receptors. There are three important receptors. We call them adrenoceptors. So adrenergic receptors are alpha, beta, and the dopaminergic receptors are the D1 and D2. Norepinephrine mainly signals alpha 1, 2, and beta 1. Epinephrine mainly signals beta 1 and beta 2. Dopamine affect the adrenergic receptors only if present in increased amount. So just to show it in a simple way, we have the hormone, which are the catecholamines will attach to a receptor in these organs and give its effect: the heart, the lungs, the skin, and the brain. The most common catecholamine that we use in our practice is epinephrine. Its signal to alpha receptor can cause vasoconstriction, increase peripheral vascular resistance. That's why we use it in patients with hypotension. It signals signaling beta 1 adrenergic receptor can increase the work function of the heart. That's why we give it in patients in shock. Its signals on beta 2 adrenergic receptor can lead to bronchodilation and decrease mediator release for inflammation. That's why we use it in anaphylactic shock and in patients with um, asthmatic attacks. Pheochromocytoma and paraganglioma are two diseases that secrete excess catecholamines. Um, it is pheochromocytoma when the tumor, chromaffin tumor, is in the medulla. It is paraganglioma when the chromaffin tumor are along the sympathetic chain ganglia. So these are the common manifestations of excess catecholamines in the circulation. For the skin and the mucosa, stimulation of the alpha 1 and 2 will cause vasoconstriction. The patient will manifest it as pallor or secretion of the sweat glands. So we have diaphoresis. For peripheral vascular, alpha 1 and beta 2 stimulation leads to vasoconstriction. So we have hypertension or vasodilatation through beta 2 receptor. So there is orthostatic hypotension. For the brain, it's stimulation of the excess catecholamine stimulation of alpha 1 and D1 will bring about vasoconstriction and manifested as headache. Unknown to a lot of us, we thought that the headache in pheochromocytoma is secondary to high blood pressure. It's not. It's more on the vasoconstriction that leads to headache. Some patients even bump their head on the wall because of this severe headache. In the heart, the stimulation of beta 1 and 2 and D1 increases heart rate. So the patients manifest this as palpitations and sometimes angina and tachycardia. And for the lungs, there is arterial vasoconstriction manifested as dyspnea. For the GI tract, the stimulation of the adrenoceptors alpha 1, 2, and beta 2 increases GI motility, and the patient will manifest this as constipation. But the stimulation of the liver glycogenolysis and gluconeogenesis may lead to hyperglycemia or frank diabetes. In the kidneys, the stimulation of beta 1 receptor will increase renin secretion that will add up to the hypertension problem. And then the adipocytes, stimulation of beta 1 and the beta 3 will increase lipolysis and lead to weight loss. So these disease process are well studied. The pheochromo and the paraganglioma, they are well studied, in which the effects of catecholamines are easily discernible, especially in situations with surmounting stress. Therefore, the potential biochemical and physiological influences of excess catecholamines in patients with COVID-19 can be well understood. Likewise, catecholamines are expected to have role in patients with critical illness, patients on vasopressor infusions, and patients who sustain some acute and chronic physical stresses. Therefore, the challenges involved in the management of catecholamine excess states are directly relevant to the treatment of patients with severe COVID-19. So let's go now to adrenoceptor mediated evolving manifestations of pheochromocytoma or excess catecholamines. In the medical school, we are taught that the clinical manifestations, signs, and symptoms of PHIO are sweating, panic attacks, palpitations, headache, and anxiety. But for the past 15 years, it's becoming different. The group of doctoral lenders in the Netherlands answered a very important question. Is the excess catecholamines and cardiovascular morbidity due to the pheochromocytoma's blood pressure or directly by the catecholamines? So what they did, they studied 109 pheos, look at their clinical features and phenotypes, and compare that with those patients with essential hypertension and their cardiovascular course as far as and events like ischemic heart disease, stroke, and TIAs. Their results showed that the blood pressure of those who have essential hypertension are even higher than those with pheochromocytoma, but the cardiovascular events are statistically higher in pheochromocytoma compared to patients with essential hypertension. So here, I would like to introduce to you that the pheochromocytoma's presentation is evolving. And we have to be aware of this because there's a matter of life and death in a short period of time. So this happens in patients in their 20s and 40s, which is characteristic of secondary hypertension. They are young. The signs and symptoms are um, agitations, the signs and symptoms of a patient under stress or panicking. But they also present with acute coronary syndrome, heart failure, and very bad arrhythmias. The laboratories are benign, but what is very prominent is the 2D echocardiographic findings of dyskinesia, hypokinesia, and akinesia of the ventricles and myocardial fibrosis by MRI. The clinical outcome can be benign as to the patient will go to normal status and regain their normal LV function and ejection fraction, or they can have a persistent systolic and diastolic impairment and even and sadly death. So this is one of our patients, a 20-year-old female diagnosed with a very big pheochromocytoma. Into the echocardiogram, she showed dyskinesia of the septum. Another case report have shown a normal angiogram. This is pheochromocytoma-related cardiomyopathy. On admission, there was akinetic mid-ventricular segment which normalized in the ejection fraction 14 days after removing the pheochromocytoma. This is a sad report of a 24-year-old athlete who presented with acute cardiac syndrome, ICU, very high troponin, and a very low ejection fraction and a very bad arrhythmia. Her metanephrines were very high, and mother eventually was found to have MEN2. It deteriorated, the patient deteriorated, and the pheochromocytoma was confirmed on autopsy. This is a very nice report by the group of Dr. De Miguel on showing cardiac edema, massive cardiac edema in a patient with pheochromocytoma pre-adrenalectomy, which resolved after surgery. Here I'm trying to introduce to you a disease they call takotsubo. Tako is, in Japanese, it is octopus, and tsubo is pottery. So there is a certain figure that is likened to the eventual event in the heart of a patient with takotsubo cardiomyopathy. So this is the normal heart, and this is the left ventricle that is normal in configuration. This is a Takotsubo cardiomyopathy where it resembles the figure of a Takotsubo Japanese octopus pot. Yung takoyaki is one of our favorites nowadays to be delivered at home. So this is an angiogram of a patient with Takotsubo cardiomyopathy. There's a compensatory inferior posterior hyperkinesia during systole, but on diastole you can see the ballooning and showing the configuration of a Takotsubo. Eventually, the Takotsubo cardiomyopathy evolved into a syndrome and has been reported now for the past 15 to 20 years. It is the Takotsubo syndrome or TTS is a reversible cardiac condition characterized by acute left ventricular dysfunction, usually in the setting of physical or emotional stress that can be acute or sadly chronic with hypercatecholaminemia. The myocytes are inflamed. Oftentimes, they present as heart failure with a very, very significant myocardial injury. There is high mortality. So when a friend tells you, hey, chillax, chillax ka lang, love your heart, save your heart, there's a lot of truth to it. Here, in this cartoon, it depicts that stress can really hit your heart. So let's move on to cytokine storm syndrome, the COVID-19 in its severe form, and the Takotsubo syndrome. So cytokines are secreted with the stimulation coming from stresses, hormones or drugs, illnesses like simple flu or worse cancer. And these stresses stimulates pro-inflammatory cells, macrophage, lymphocyte, granulocyte, endothelial cells, fibroblast mast cells to produce cytokines. The cytokines are proteins, peptides, glycoproteins that can crosstalk to each other. No? They can have an effect on their neighboring cells, and they regulate immunity, inflammation, and the blood, hematopoiesis. They even dictate the growth and survival of a blood cell. Some cytokines may reduce and sadly may even worsen inflammation. Cytokine storm, which I call tsunami of cytokines, is a state of hyperinflammation. This is a case report of an 83-year-old female who had pneumonia secondary to COVID and a fatal Takotsubo syndrome. The ECG showed diffuse ST segment and Q waves precordial and peripheral inferior leads. The angiogram showed ballooning of the left ventricle with the normal LAD and RCA, or normal arteries, main arteries. The, the patient died, and on autopsy of the heart, it showed hemorrhagic area, and an opening up, there is epicardial surface extension. In COVID-19, there is fulminant cases at that, there is cytokine storm, or what they call cytokine releasing syndrome, demonstrated by elevation of these inflammatory cytokines. The COVID-19 patients showed low left ventricular ejection fraction, high volume of left ventricle, high sensitive troponin, and higher MRI markers of inflammation. The cytokine release syndrome is oftentimes accompanied by catecholamine surge, which can predispose a patient to develop Takotsubo syndrome during that stage of COVID-19 infection. The group of Sharma studied COVID-19 patients that were diagnosed at the same time with Takotsubo syndrome. Their presentation, majority were dyspnea and chest pain. The uh, echocardiographic results showed 100% of them with wall motion abnormalities, and the electrocardiogram showed T-wave inversion and sinus tachycardia. The in-hospital complications are acute respiratory syndrome, kidney failure. The outcome, some went home well, but one had to stay more and longer in the hospital, and two died. So majority of the patients were given anticoagulation. The oral anticoagulation therapy should be considered in high-risk COVID-19 patients with Takotsubo syndrome because of dilatation of the ventricles, especially in older age group and those with reduced ejection fraction. The treatment given to the patients were hydrochloroquine, antivirals, vasopressors, and beta blockers. Five patients were given anti-interleukin interleukin 6 inhibitor. All patients treated with this drug, which is tocilizumab, had improvement either clinically or in laboratory, improvement in their laboratory findings. 54.5% over 50% develop cardiac complications like shock, atrial fibrillation, heart failure, tachycardia, and 73% were discharged, but those with ARDS needed extracorporeal membrane oxygenation. What is significant here is 14.8% who died had Takotsubo syndrome versus the 5.8% without the Takotsubo syndrome. So TTS in COVID-19 patients has no major gender differences. The older median age among these patients, irrespective of cardiovascular comorbidities, reflects age as an independent risk factor. TTS in COVID-19 have higher mortality rate from cardiogenic shock. Early diagnosis and management of this syndrome and combination may decrease in hospital mortality and cardiovascular complications. All high-risk patients with COVID-19 should be screened for TTS, and optimal treatment should be considered with antiplatelet medication and even beta blockers if indicated. I encountered recently, the past 2 weeks, a case report of COVID-19 vaccine associated Takotsubo cardiomyopathy. She is a 65-year-old female. Her comorbidities were asthma, glaucoma. She had nephrectomy 11 years ago for a cancer. She was stable. 2 months ago, she had a workup because of lightheadedness and showed negative COVID. All other markers were negative. On multivitamins, she was on beta blocker ophthalmic drops, timolol for her glaucoma, and she had no physical or mental stress. She received her first dose of Moderna, which is an mRNA 1273 SARS-CoV vaccine. 3 days later, she experienced myalgia, nausea, fatigue, headache, shortness of breath, 7 to 10 times chest pressures. She had bradycardia, elevated troponin, but the rest were normal. This is her electrocardiogram with inferolateral ischemia, and the angiogram showed that feature in of a Takotsubo syndrome, which is dilated left ventricle. There was hypokinesia with an ejection fraction at 35, which was low. She improved at the last day of her hospitalization. She was sent home with aspirin, lisinopril, atorvastatin, and a low-dose metoprolol succinate. On 5 weeks of follow-up, her ejection fraction improved to 60 to 65%. What happened to her, the pathophysiology was believed to be related to an acute rise in catecholamines post-vaccination with resulting microvascular spasm and myocardial dysfunction. So let's move now to a model of high catecholamines and the COVID-19 infection individuals. So the model here is there's catecholinergic effect and situation over on top of the COVID-19 infection. So there were 3 patients diagnosed with pheochromocytoma. They were 60 years old, 67 and 84. And they are for surgery. They manifested the classical pheochromocytoma symptomatology. They had to undergo RT-PCR because of the admission. All of them were positive but asymptomatic. So post-operative, they showed very big pheochromocytoma with benign characteristics histopathologically. Their hormonal profile was high, plasma metanephrines, very, very, very high in thousands, and urine metanephrines that were also high. They were all managed with adrenalectomy. Perioperative course was uneventful with resolution of the pheochromocytoma symptoms. The patients remained asymptomatic as far as their COVID-19 infection was concerned until discharge. What's the insight? The insight here is although there was marked increase in catecholamines due to the pheochromocytoma, the clinical course of the patient with COVID-19 was uneventful. The absence of cytokine storm could have been a factor for the uneventful clinical course of the COVID-19 infection. So at this point, I would like now to introduce the issue we raised in our title for this lecture. Could it be that the deadly duo in COVID-19 are the surge of catecholamines in the presence of a pre-existing cardiovascular abnormalities in an environment of hyperinflammatory state due to cytokine storm, which means, as far as I am concerned, thinking and analyzing it simply, a hypertensive or diabetic patient should not be doomed and cursed to die when they have COVID-19. It is the pre-existing cardiovascular abnormalities that could be a factor if they go to severe stage of the infection that will be deadly. So we have two, the cytokine catecholamines that is high in excess, and that's the model. And another model is the cytokine storm in a patient with in the stage 3 COVID-19 infection. So we will marry them and see what happens to the different system and organs of the body. As early as January 2020, the first Wuhan report, they already identified comorbidities or risk factors that will lead to complications of severe COVID-19. And these are hypertension, diabetes, obesity, coronary disease, and heart failure, which have high mortality and high morbidity. So let's talk about this hypertension, coronary disease, and heart failure. So in COVID-19, there are three stages. The first stage is the entry of the virus, which is the stage one, and replicate. So during this stage, the patient may be asymptomatic or very mild, losing the smell or appetite and taste, just a body ache, fever, flu-like. Okay? You may recover from it, depends on your immunity and how much you killed the virus that entered the body. But when you are unable to do that, your body is unable to do that, it will go to stage two. The stage two is now where the cells are reacting to the virus, and the antibody complex stimulating several cells and inducing inflammation. And this is the time now that the patient will have cough, the colds, X-ray will be positive, and some may have diarrhea. And again, if you cannot control it at this stage, the disease is not controlled at this stage, there is this hyperinflammatory state, which is the cytokine storm state, where now the patient will have difficulty of breathing, so much damage now on the lungs, needs ICU, high oxygen is needed, heart failure, and some organ failures. Okay, so the virus enters, we need antibody, that reaction will stimulate several cells, and these cells are what I call avengers that will kill the virus. This is what we want to happen only in the first stage. But unfortunately, it does not in some individuals. So let's talk about now COVID-19 infection, the severe form, with a catecholamine surge through mediation of adrenoceptors. The reaction and the process of both will involve multi-organ system in the body, like the heart, the liver, the pancreas, the lungs, hematopoietic system, and the uh, immune system. So let's talk about the renin, angiotensin, aldosterone, and cardiovascular system. There is 2 to 3 times higher deaths in COVID-19 patients who are hypertensive. There is likelihood that they will be ICU'd and intubated. We know that the entry of the virus is through the enzyme ACE2. That ACE2 is important to convert A2 to A1. So A2 is the vasoconstrictive um, form of the angiotensinogen. The A1 to 7 is the vasodilatory form, which has an anti-inflammatory peptide. However, ACE2 is degraded during this infection, and there's excess A2. When there is excess A2, there is a vasoconstrictive effect, and that will lead to cardiovascular events. 71% of COVID-19 patients die from fatal CV complications like MI, arrhythmia, stroke. Acute catecholamine surges increase the risk of these individuals and will have a lethal complications like cardiomyopathy, hypertensive emergencies, and MI and myocarditis. So the effect of excess catecholamines on these receptors are, just to summarize, vasoconstriction that will lead to hypertension, hypertensive crisis, and shock. But there is beneficial effect aside from deleterious effect. The catecholamines can have a vasoconstriction and compensate for the shock, but this does not happen, and we don't see it because the system is overwhelmed with cytokines. How about diabetes and obesity? So, um, hyperglycemia per se will dysregulate the immunity. When the blood sugar is high, the WBC cannot function well and some other important cells. Both type 1 and type 2 are risk factors for severe COVID-19. Diabetes is significantly independently associated with COVID-19 related mortality because of the eventual ARDS, septic shock, kidney failure, and thrombosis. In Hubei province, China, the report showed that patients who had type 2 diabetes had significantly higher mortality than patients without diabetes. Thrombosis, because these patients are, they also have the hypercoagulability property or characteristics. So the excess catecholamines, the deleterious effect of excess catecholamines through alpha 2 receptor will have a beta cell dysfunction effect leading to hyperglycemia or worsens the diabetes of a diabetic COVID-19 patient. The beneficial effect, though, is catecholamine-induced hyperglycemia can counteract the hypoglycemia in COVID-19 infection. Again, unfortunately, this we don't see this to happen. How about obesity? The fat cells, for us endocrinologists, they are known to be endocrine organ. One fat cell is an endocrine organ because it has the capability to produce a lot of substances and hormones and crosstalk with other cells. So this is a lean adipocyte. It is the white adipocyte that reacts to stress. There's a brown and beige adipocytes or fat cells, but they are for energy and not for reaction to stress. The white adipocytes can crosstalk with some pro-inflammatory cells. This cross-talking will bring about interleukins in the circulation. Just imagine, in obese patients, the fat cells are bigger and more. So when there is stress, the cytokines that will come out from the cross-talking, the pro-inflammatory cells will be a lot. So in stress, there is secretion of norepinephrine from sympathetic nerve ending. It has been shown that norepinephrine is a very good stimulus to increase interleukins in the circulation. So during severe stress, which here we're talking about severe COVID-19 infection in obese patients, the white fat cells are the ones reacting, but in severe stresses, the brown and beige fat cells will participate in this cross-talking with inflammatory cells, producing a tsunami of cytokines. And that's the reason why we see the reaction of obese patients with severe COVID-19 and a very, very sad higher mortality. So what are the other systems involved in severe COVID-19 infection aggravated by acute catecholamine surge? The lungs. COPD and asthma with COVID-19, they have high mortality and also morbidity. The reason why there is ARDS and destruction of the lung tissues is the diffuse alveolar damage by the hyperinflammatory state with granulocytic infiltration of the bronchi and the alveoli. So through the alpha 1 and beta 2 stimulation of excess catecholamines during an acute surge, there is vasoconstriction of well-ventilated alveoli that will lead to intrapulmonary shunt and then hypoxia or hypoxemia. The decreased secretion of the bronchial gland and the improved ventilation is overwhelmed by the cytokine tsunami of cytokines. It is overwhelmed and overtaken by this situation, and we don't see the improved ventilation. So how about the cytokines in the immune and hematologic system? So there is elevation of the cytokines during this severe COVID-19. The cytokine storm results from uncontrolled immune system activation. There is increase in acute phase reactants, which we use now to prognosticate a patient, um, the ferritin, if the patient will be entering a very serious stage of the infection. Lymphopenia in COVID-19 also is used as a prognostic indicator of disease severity. Another important, I think,
Dr. Asis. I think Dr. Asis is having some technical difficulties. I will just call her po.
Nakamute ako. Sa'yo na rin.
Ayan, Dr. Asis is back po. Good morning po again, Dr. I will stop sharing po.
okay. So this is very important for me, especially now that we see. I don't know if this is related now to the uh, blood clots that we see in patients who receive the vaccine, but in cytokine, in increased cytokine levels, there is hypercoagulability. There is the hypercoagulable state will lead to thrombosis. So the excess catecholamines effect on beta 2 and alpha 2 is the formation of thrombosis, and chronic catecholamine can cause natural killer cell reduction, which is important in the halting the progression of the disease. So there is also platelet aggregation and inhibition of antigen presentation, lymphocyte proliferation, and cytokine production, greater susceptibility to SARS-CoV-2 infection. The beneficial effect, which actually we do not see, is the fibrinolytic effect of catecholamines. And unfortunately, again, we don't see that in here. How about the elderly? So we know that the elderly's immune system is already lower compared to younger individuals. And they are also the ones who have a lot of comorbidities, the ones that we mentioned earlier. And that's the reason why the elderlies are, again, sadly, can succumb to the serious complications of COVID-19 infection. So now we are into the role of alpha and beta adrenoceptors and their blockade in curbing the fatal course of severe COVID-19. So using catecholamines in the treatment of COVID-19, is it a friend or a foe? I've shown you earlier this slide where epinephrine has a multifaceted clinical utilization in shocks, in asthma, bronchial asthma, inflammation, anaphylactic shock, and hypotension. But the narrow therapeutic, there's only a narrow therapeutic window of epinephrine. The adverse effect is easily seen. As you can see, when we administer epinephrine in our patients who needed it in anaphylactic shock or in patients with simple allergy and asthma, they experience agitation, anxiety, headache, and palpitations. If given in overdosage form, it can lead to MI, heart failure, arrhythmia, and stroke. Vulnerable populations then should be monitored, especially the elderly and those with hyperthyroidism that is not diagnosed, probably, and cardiovascular disease. In some settings, the epinephrine drug, its pharmacologic property is not the one that is being used, but they look at the micropulses. As a background, less than 3% of patients who are young and hospitalized for COVID do not need ICU admissions, and fatality is low, compared to more than 31% of elderly patients admitted to hospitals, resulting to ICU admissions and increased case fatalities. Here, they said that circadian amplitude of the epinephrine rhythm is higher in children than in the elderly. In fact, the when somebody is being given nebulized beta agonist medicines, they observe decreased severity of COVID-19 in these patients with asthma. Another kinetics and pharmacokinetics of epinephrine use, its effect on inflammatory cells and production of cytokines. Here, the natural killer cell activation depends on the involvement of CD8 T cell. In H7N9 disease, patients were found to have early CD8 T cell responses for those patients who recover from this viral infection. For mounting an antiviral immune response, a certain degree of adrenergic signaling by catecholamines is required. CD8 T cells were positively correlated with epinephrine oscillations, and their population increased after low dose epinephrine infusion. How about blockade? So, alpha 1 adrenergic receptor blockade versus cytokine storm. I've shown you that with stimulation of alpha 1, there is vasoconstriction of aerated alveoli leading to hypoxia. Some group studied and give prophylactic inhibition of catecholamine synthesis using metyrosine, a tyrosine hydroxylase antagonist, which reduce levels of catecholamines and cytokine responses with markedly increased survival following various inflammatory stimuli in mice. The alpha 1 antagonist prazosin prevented cytokine storm, requirement for mechanical ventilation, and reduced mortality in patients when on this medication prior to hospitalization for COVID-19. How about blockade of beta 2 adrenoceptor signals? This is lessons learned from cancer patients. So again, the beta 2 can lead to in, intrapulmonary shunting. The beta 2 stimulation can lead to intrapulmonary shunting and hypoxemia. With the alpha 1 blockade and beta 2 adrenoceptor, it can precipitate hypotensive shock or distributive shock in patients with COVID-19. Um, Propranolol inhibits choroidal neovascularization in patients with retinal pigment epithelium, which is a alpha blocker, non-selective beta adrenergic blocker. So it reduces inflammation and inflammatory cytokines in patients with cancer cells, including interleukin 6 and TN alpha, and decreases platelet aggregation. This is very nice from Barbieri and his group, where they identified the specific action of beta blockade, beta 2 blockade, targeting the different stages of COVID-19. If you want to target the stage where there is and blocks the mitogen activated protein kinase which is involved in virus replication. You can put the beta 2 blockade drug during the phase 1 or stage 1 of COVID-19. But if you want to target and decrease the macrophage recruitment in lung tissue and inflammation, put it in stage 2 if you encounter that patient in stage 2. But in stage 3, putting your beta blockers will increase interleukin 12, which potentiates the cytotoxic activity of killer cells and decreases interleukin levels. So this is the different areas where we saw reports where they place the different treatment for um, COVID-19 infection. So probably depends on where you got the patients. Beta blockers can be started from here down the line. Last topic is interleukin affecting adrenal medullary secretion of catecholamines. Interleukin can affect and influence and alter gene expression in the medulla and can affect the secretion of catecholamines and its reaction to stress. Here you can see interleukin 6 on the other side, vice versa, can be influenced by the presence of high level of norepinephrine. Norepinephrine is one of the most potent stimulation for the production of interleukin 6 in rat cardiac fibroblasts. So recently, they've shown that interleukin 6 can be a potential biomarker of COVID-19 progression. Here in this dozen reports, they were able to show and statistically that indeed interleukin 6 is a potential biomarker for COVID-19 progression. So circulating interleukin 6 are linked to severity of the infection. It implies a shared mechanism when it is increased with the cytokine-mediated lung damage. It has the highly pathogenic SARS-CoV-2 is associated with rapid virus replication. And in that stage, there is elevated response of interleukin 6. It is responsible that immediate initial evaluation of this is important so that we will know who among these patients will need intensive management and admission. So they look at the effect of an interleukin 6 inhibitor, which is tocilizumab. There's another one that is sarilumab. Both are used for rheumatoid arthritis and repurposed for the treatment for COVID-19 infection. They hypothesized that modulating the levels of pro-inflammatory interleukin 6 may improve the course of COVID-19. But at this time, there's no FDA approval yet. So indeed, giving this compound can decrease mortality and time to ICU discharge, shorten the ICU stay, and increase discharge of these patients with severe COVID-19, and increase the number of organ support free days. But there are studies that were also negative. So I'm almost close to the end of my lecture. These are the summary and insights, my insights. One, acute catecholamine surge can influence the course of severe COVID-19. Increase in catecholamine secretion is associated with increase in pro-inflammatory cytokines and vice versa. Increased catecholamine levels can augment production of concentrations of pro-inflammatory cytokines. The cytokine storm leads to cardiovascular collapse, multi-organ dysfunction, and death in COVID-19. There is increased mortality in severe COVID-19 patients with acute catecholamine surge as seen in Takotsubo syndrome. The catecholamine adrenoceptor blockade showed a reduction in morbidity and mortality in patients with severe COVID-19. So, are catecholamines friends or foes in the treatment of COVID-19? I think timing is critical and vital in either using the alpha and beta receptor agonist or antagonist in manipulating the course of severe COVID-19 for patient survival. However, indeed, the deadly duo are an acute surge of catecholamines in a patient with severe COVID-19 with pre-existing cardiovascular abnormalities. And that actually emphasizes that the hypertension, the diabetes, and the obesity should be controlled anytime, anywhere, any day. So that when you are subjected to an environment of hyperinflammatory state, the course will not be as bad. So early recognition of this duo and manage optimally and very timely could be critical in reducing mortality in patients with severe COVID-19. This is my last slide. Thank you very much for your kind attention.
Thank Thank you very much, Dr. Asis, for your extensive and superb lecture from the pathophysiology to the symptomatology down to the clinical presentation and correlation. You also emphasized the importance of multidisciplinary collaboration with our friends from cardiology, nephrology, rheumatology, and ID, of course. I am now formally opening the virtual floor for our open forum. Should the participants wish to speak through your microphone instead of writing your question, kindly raise your hand so you can be acknowledged po. And for those who are in our YouTube, no, there are 37 to 40 of them there. If you have any questions po, kindly write it in the YouTube chat box as well. So Doctora, I think we have some questions na po in the chat box. Let me read them po. The first question comes from Dr. Robert Chan. There were studies that state surgery for COVID positive should be delayed until 7 weeks. Is it safe to do surgery for asymptomatic patients who are positive for COVID? If yes, when is the earliest time for safe surgery?
I think now from that lecture, there are two, we need two to tango. One is the infection and the other one is the cardiovascular status of our patient. Patient may be asymptomatic as far as the COVID-19 infection is concerned, but you have to assess their cardiovascular makeup. How did they control their blood pressure, and if ever diabetic, how did they control that? Because whatever happened in the past may have important bearing at present when the patient gets the infection. So for me, now it is very, very important to assess the cardiovascular makeup of a patient prior to surgery.
Okay, so
Because surgery is stress. Surgery is a state of acute catecholamine surge.
Opo. What about Doctora if it's an emergency po, surgery, if not an elective po?
So there is cardiac monitoring. Like what you said, it should be multidisciplinary situation where you have all the important people in the operating area so that they can and be ready for whatever consequence the patient may have.
Okay po,
As
Doctora.
long as everybody is ready, I think the patient will be managed well and excellently.
Okay. So, Doctora, thank you for that. There's another question po from Dr. Katakutan. In patients who were vaccinated against COVID-19, is it correct to say that there is a possibility that some of the patients, especially those with comorbidities, may develop cytokine storm after vaccination that may lead to the fatal adverse event following immunization?
Yes, I've given you a case report where a patient developed Takotsubo cardiomyopathy 3 days after the vaccination. In fact, the Takotsubo cardiomyopathy after vaccination has been also reported in a simple flu vaccination, not only a long time ago. So for me, the lecture is an eye opener. It does not only emphasize that we have to take care of ourselves now that there is pandemic. I think we have to take care of our hypertension, of our blood pressure, of our blood sugar, and the rest of our system. Because if the infection gets in and you are not ready and your system is not ready and already with complications, that's the time that management may be very, very challenging.
Okay. So I think, Doctora, there are no more questions in the chat box. Let me see the participants po if there are any who has raised their hands. So far po, Doctora, I think the lecture was pretty straightforward and clear as well. And there are a lot of commendations po from the chat box po. I think from from your batchmates po earlier on, and now po to your other colleagues po. So thank you very much po, Doctora Asis, for that very wonderful lecture. So if there are no more questions po, I would like to call on Doctora Kalimag to award Doctora Asis for this certificate of appreciation.
Good morning again. Tora Asis, classmate, thank you very much for your time and for sharing with us your expertise. As I now present you with the Certificate of Appreciation. The University of Santo Tomas Faculty of Medicine and Surgery, in celebration of its sesquicentennial Foundation Day, through the Office of Continuing Medical Education, presents the Certificate of Appreciation to Dr. Leilani B. Mercado Asis for invaluable services rendered as webinar lecturer on the topic Acute Catecholamine Surge and Cytokine Storm, Deadly Duo in Severe COVID-19 Infection, during the sesquicentennial celebration of the UST Faculty of Medicine and Surgery, May 23, 2021, UST. Signed by myself as Project Head, Dr. Ivan Villaspin, Chief Program Officer of CME, Dr. Jocelyn Mariano, USMA President, and our very beloved Dean, Dr. Maria Lourdes D. Maglinaw.
Okay, I'll just
Dr.
take a
Asis,
screenshot. Okay.
congratulations.
So again, thank you very much po, Dr. Asis, for your time and expertise po. So at this point in time, I would like to call on Dr. Ivan Villaspin, the Chief Program Officer of CME, for his closing remarks.
This year, today is a celebration of gratitude and joy as we distinctly commemorate UST Faculty of Medicine and Surgery 150 continuous years of educating and contributing to the world an array of Tomasian physicians. We once again provide an innovative, highly relevant academic discourse given during a disruptive time. This could have not been made possible without the collaborative partnerships and commitment of the following, to whom I would like to express my profound gratitude. Dean Odette Maglinaw for her inspiring leadership, the CME SESCI Webinar Project Team, with the indefatigable Dr. Irby Kalimag at the helm, complemented by the hardworking, proactive Dr. Tina Marañon, Drs. Marga Geliaco, Joe Mariano, and Earl Sempio, our technical support staff, Noel from the Office of CME, and Marvin from MIC. And lastly, certainly not the least, our featured speaker, the multi-titled and awarded Professor Leilani Asis. Her discourse on cytokine storm made me reflect on this beautiful and timely quote by Mahatma Gandhi. The dignity of human nature requires that we must face the storms of life. So may the good Lord spare us from this storm. Let me wish all with this famous Irish praise. Safe home and stay home safe. Thank you.
Thank you very much, Dr. Villaspin. So before we formally close this with our UST hymn and a photo op afterwards, I would like to request our dear delegates for this morning's webinar to kindly accomplish the evaluation form posted here on the screen. So you can access this via typing the link and via clicking on the link also that was sent by Dr. Kalimag earlier, and by scanning the QR code. So please stay on after the UST hymn for our picture taking. Thank you very much. May I please request everyone, all our delegates, to kindly turn on their cameras for our picture taking.
They can actually get the replays on YouTube, which I posted on the chat box.
Yes po. So I will be taking a screenshot po for the first panel in 3, 2, 1. Smile. Okay. Moving on to the second page. Hold that smile in 1, 2, 3. For the third panel po, keep that happy face. 1, 2, 3. And lastly po, 1, 2, 3. Thank you very much again, everyone, for attending this lecture, and we hope to see you again in our succeeding webinar series. Thank you and good day po.
Thank you, Lani. Thank you, Lani, Irvi, Ivan, and Tina. Thank you.
Doc Mimi.
Thank you, Mimi. Ate Mimi.
Thank you, Lani.
Congratulations.
Congratulations, Lani.
Dr. Assis,
Thank you,
congrats
Irvi.
po.
Ate Irvi, tuloy-tuloy na ito, Ate Irvi.
And hello to our Magilas 1981 class.
Hi, classmate.
My classmates. Hi, Sister Arlene. And pamangkin.
Adopted.
Hi, Lani.
Ay, hello. Rene. There's Helen and ang daming pinsan.
Pwede ba mag-picture take